5 surgeries for gastric ulcer a week. Now, I would say we do less than 10 a year, and that's for surgeons that actually are being known in the community to do gastric surgery and all of that. Proton pump inhibitors, those are fighting the ulcer disease through another mechanism by actually blocking the secretion right there where it starts in the stomach. And treating this is actually, with PPIs, gastric ulcer, is actually better than surgery. Because surgery usually involves removing part of the stomach that secretes the acid and cutting the nerves that are stimulating the acid. The proton pump inhibitors are actually interrupting not just the nerves that secrete, that stimulate the acid, but they're going to stop other mechanisms of secreting acid. A lot of percentages basically showing that there are a lot of people for which this medication that is wonderful, that makes sense, but still doesn't help. You see, 45%, the one before the last line, medication does not relieve all symptoms. So there are a lot of people that are on these medications every day, and they still have some persistent symptoms. And it actually makes sense that some of these symptoms of reflux are not going to be treated by medication, because I wasn't talking about the amount of acidity that the stomach has generating the reflux. I was talking about an anatomical malfunction, right? So it makes more sense to deal with the anatomy than to actually give some medication to take care of this reflux. And this is why I put there that anatomical changes are going to need anatomical repairs. The medication might help to some extent, but not for everybody. There are some risks with the PPIs, the proton pump inhibitors. They increase the risk of osteoporosis. They increase the risk of gastric polyps, and those gastric polyps usually are benign, but if they're not removed in time and properly treated, the sequence of developing cancer in the human gut is from a small polyp to a large polyp to a small cancer. So I don't believe that there is a medication on this planet that doesn't have side effects, including the PPIs. Some patients are going to say, I don't want to take drugs for life, because the gastroenterologist is going to say, I'm going to have to put you on protonics, and chances are you're going to be on protonics for the rest of your life. Otherwise, you're going to continue to sleep on 5 pillows. You're going to continue not to be able to eat anything that you like. You're going to eat only things that have no taste and that give you no reflux. So if the patient doesn't want to take these drugs, considering also the expense of the drugs, then surgery might be a consideration. On top of that, there is another thing called non-erosive reflux disease. So there is like a silent disease that can generate the Barrett's esophagus and the esophagitis and even the cancer without us knowing it. Other complications of PPIs, vitamin B12 deficiency with anemia, increased pneumonia risk, as it was recently demonstrated. What happens is the acid in the stomach is another barrier to the bugs that we're ingesting or that we are in contact with. So if the acid is gone inside the stomach, then bacteria can go down in our system unhindered and can generate diseases, including pneumonia. Reduced gallbladder motility. So the gallbladder becomes lazy, then the next step is gallbladder stones, then gallbladder pain, then acute cholecystitis. Increased risk of osteoporosis. As I mentioned, there's something that is very important nowadays. PPI interaction with Plavix, right? There are a lot of people that are on Plavix because they have stents in their hearts, right? And Plavix is an antiplatelet agent that is meant to keep those pipes open after the cardiologist, the interventional cardiologist, put the stents in the heart. If you don't take the Plavix, those things can clog, and that's called a heart attack. Taking PPIs with the Plavix decreases the efficiency of the Plavix and puts patients with stents at risk of a heart attack. So you see, it's very difficult to deal with situations like these, as nowadays physicians deal with patients that are sicker and sicker, have more and more problems, had surgeries before, had open heart surgery, or had the bypass, or had the vascular surgery. So sometimes it's not easy to choose the lesser of the evils when you're treating patients. So the whole idea of this talk is that there are other solutions as well that should be considered. What are the indications for surgery? Well, first of all, surgery should never be the first choice. Okay? I'm not here to sell anybody any surgeries if that can be avoided, because I like to treat my patients as I would treat my family. So if I do this, then I'm going to try to avoid an operation, if at all possible, for my patients. Sometimes it's not possible. Like I was telling you, these youngsters that have bad reflux, that are already on double dose proton pump inhibitors, and the gastroenterologist says, there's not much I can do. That's it. So, indications for surgery: esophagitis. At the moment the gastroenterologist says, oh, you have esophagitis, I'm going to give you some treatment for that, and then I'm going to scope you, and I'll see in 3 months if that got better. So they scope you in 3 months, and it didn't get better, it got worse. So that's probably an indication to consider surgery. If you have PPIs required for control, which basically means everybody that has any reflux nowadays, persistent symptoms despite medication, and an inability to deal with one's day-to-day life, you know, the presence of Barrett's esophagus, that precancerous condition that I was telling you about. Not all the Barrett's esophagi are going to turn into cancer. All right? And what surgery does to the Barrett's esophagus is it stops its progression. It doesn't make it go away, but it stops it right there. And that means that chances are it's not going to degenerate into cancer. Non-acid symptoms of reflux, asthma, chronic cough, laryngitis. You know, I have a bunch of people that are coming to me from their pulmonologists. The pulmonologist says, you know, I don't know, I keep giving them nebulizers for the asthma, and it doesn't help. there are a bunch of tests that have to be done before surgeries. Everybody knows that. And for this particular surgery, dealing with the gastric esophageal reflux, the tests include endoscopy, and I talked about endoscopy. In my opinion, nobody should be on proton pump inhibitors without having an endoscopy, because just plain reflux should be a diagnosis of exclusion. So everybody should have, with reflux, should have an endoscopy just to make sure that it's just reflux. And then the gastroenterologist or the primary doctor can put you on proton pump inhibitors. Because then it's safe. You know, if somebody has reflux and actually has cancer hidden in there, never had an endoscopy, and you're going to try to treat cancer as the gastroenterologist or the primary doctor with proton pump inhibitors, it's not going to work, right? Barium swallow is the second picture, the black and white picture. So the patient has an X-ray while swallowing this contrast material. And what that shows is it shows the geography of the area there and shows how the barium, the contrast that is going to just go up back into the esophagus instead of continuing to go down. So it's gonna, the esophagus is going to empty, and then it's going to fill back up a little bit with barium, proving the reflux. pH monitoring, pH means acidity, is the marker, the measurement for acidity. So the patient is going to swallow a wire, basically, that is going to measure the acidity in the esophagus for 24 hours. When he is going up and about, when he's sleeping, when he's eating, and everything. And then that measurement here is going to make the physician determine how bad is the acidity in the esophagus and for how long out of the 24-hour period. Manometry, you know, the tire pressure monitors are manometers. So they're measuring pressure. And what the manometer does in this situation is it measures the pressure inside the esophagus and especially at the level of the valve. So if the pressure in the valve is less than a certain amount, that means the valve is not going to hold the acid and the acid is going to go back. Manometry is also important for the surgeon the moment the surgeon thinks the case over to determine what's the best treatment, surgical treatment for this, whether it is what I'm going to talk about, the incisionless fundoplication, or the more conventional surgeries for this. There are certain variations that need to be taken into account depending on how well the esophagus on top of this valve is working. Because what happens is this. Now I need to close this valve. If I make it too tight and the esophagus doesn't have the muscle to squeeze things through, then I'm going to have a blockage there. So this is where the manometer comes into play. So the surgical treatment is trying to recreate the natural valve. And Dr. Neeson was one of the first surgeons to do this, and he did it in an open fashion, open surgery. Cut right here, mobilize the lever of the diaphragm and push it away, find the area there. It was quite an extensive operation. Nowadays, my associate and I, and people that have our type of training, can do this laparoscopically. You see that those instruments are put in through small holes. These instruments, like one here and one here, they're put in through small holes through the patient's abdomen, and we can do the exact operation that Nissan did many years ago through these small cuts instead of using a midline cut, and obviously that should have the same results, and